Hello, my dear future nursing officers. I welcome you all once again back to the Master Nursing classes where the most complicated things are made easy, and very easy for the aspirants who are preparing for the upcoming Norcet exam and any other state and central government exams. So this is the one-step solutions to clear your Norcet exam. So that is to just follow the Master Nursing classes and the Master instructions. So that is very valid for your exam and that is very valid to get the best rank. Okay? Yes. So in the last session, we have done the lots of the important concepts. So in the today's session also, we are going to deal and discuss the most important and the very high yield key golden questions and the most important key golden points, everything that is necessary for our exam. We are going to start now here. Okay. So and most importantly, dear students, in this particular session, the concept wherever I am explaining and wherever I am telling that is important. So please do be very cautious in that one and very focused in that one. So because that is favorite to examiner and from there may be a chance of striking the MCQ. So you must and should have the clarity of the concept over the few topics that is must and should to revise before the exam as well. So we are going to cover those questions now here. Okay. And yes, just stay connected till the end of the video and watch the video perfectly. And if you have any doubts, you can mention it out. Okay. Yes. So very good evening to one and all. So namaste, welcome and vanakkam. Good evening, very good evening to one and all. So hope everybody's preparation is going very well. Okay. So yes. Good evening. Well done. So can we start the session now? Can we start it now? Yes, we can start it now. I hope video, audio, everything is clear. Fatafat every one of you do thumbs up and let your friends also join to the session. Is that video, audio, board, everything is clear? Okay. So let me take you a beautiful ride over the learning of the important points here. So here it comes to the first question of the class. Okay. So fatafat everyone who are live to the session. So please do hit the like button. Okay. So I try to give the best answer to this question. Which of the following is the drug of choice for managing the GDM, that is the gestational diabetes mellitus, when the medical nutrition therapy is going to fail? So after the failure of the medical nutrition therapy, okay, so which one is the drug of choice for managing the gestational diabetes mellitus is the question. So option A and B is about the oral hypoglycemic agents, that is the metformin and glyburide, and option C is insulin, and D comes here is the labetalol. So what is your correct answer? Yes, well done. So every one of you have mentioned that is the option C as a correct answer. That is the insulin is the very perfect answer for this question. So dear aspirants, here we have to be very clear about the two things. One is gestational diabetes mellitus, another one is the overt diabetes mellitus. Sir, what is the gestational diabetes mellitus and what is the overt diabetes mellitus? So consider here we have the two females. Okay, so here we have the female number A. So here we have the female number A and here we have the female number B. Okay, yes sir. So when we will check the blood glucose level of this female before the pregnancy, so that is normal, and first 24 week of the pregnancy, whenever we are going to check the blood glucose level, that is also normal. Okay, and once after 24 week of the pregnancy, whenever we are going to check the blood glucose level, so that is increased. So this is increased because of the resistance against the insulin by the human placental lactogen hormone. So this HPL hormone is creating the resistance against the insulin. So the HPL creates the resistance maximum at the 24 to 28 weeks. So that is the reason here the maximum resistance by the HPL against the insulin. So that is the reason after the 24 week, the blood glucose level is going to increase. So this condition is called as in the gestational diabetes mellitus. This condition is called as the gestational diabetes mellitus. Okay, so the woman number B we have here. So for this woman, whenever we are going to check the blood glucose level before the pregnancy, that time also it is high. Before the 24 week of the pregnancy, so that time also it is high, or the first 24 week of the pregnancy when we can say that is also high. and after the pregnancy also that is high. Means what happened here, before the pregnancy also blood glucose level is high, means the diabetic patient is there. So this particular diabetic woman, she will get pregnant. Okay, she will get pregnant. So when the diabetic woman will get pregnant, so this is called as in the gestational, sorry, this is called as in the overt diabetes mellitus. So I hope it is very much clear. Two conditions. One is the gestational diabetes mellitus, another one is the overt diabetes mellitus. It means already woman is diabetic, she now got pregnancy, so that is called as the overt diabetes mellitus. And woman is not diabetic before the pregnancy, after the pregnancy, after 24 weeks, due to the resistance by the HPL, that is the human placental lactose hormone against the insulin, the blood glucose level is increasing, means the diabetes is happening due to the gestation. Diabetes is happening due to the pregnancy, that is the gestational diabetes mellitus. And here overt diabetes mellitus means already woman is diabetic, so she got pregnant, so this is called as the overt diabetes mellitus. So how we are going to approach the treatment in this both condition? So what is the treatment in this both condition? So you can see the treatment in this both condition. Whenever there is the overt diabetes mellitus patient will comes to us, here there is no any role of the diet, means medical and nutrition therapy is not indicated in the overt diabetes mellitus. It is not useful in the overt diabetes mellitus. No role of the diet, no role of the exercise in the overt diabetes mellitus. Directly we are going to start the drug of choice, that is the insulin therapy. Okay, and remember the most important, during the pregnancy there is increase in the need of the insulin is there. Okay, so if already woman is the diabetic, she is taking the insulin, and in the pregnancy, you know, because of the HPL there is a resistance against the insulin, so that is the reason the more dose of the insulin is required here. Okay, during the pregnancy, increased dose of the insulin is the very, very important thing to be keep in our mind. But when the resistance is happening, after the 24 week, right? So that is the reason here in the first trimester we will not increase the dose of the insulin. We are going to increase the dose of the insulin only in a second and third trimester. So this is a very, very important thing to be keep in our mind. So one liner single question is, in the pregnancy the need of increasing the dose of insulin is there or not? Yes sir, it is there. So is this need to increase in the first trimester? No need sir. Then when we need to increase the dose of insulin sir, that is after the 24 week we can say, or in the second and third trimester we are going to increase the dose of insulin in the pregnancy. So this is the very, very important you are going to keep in our mind. Okay, now you tell me yes or no option. Yes or no option answer you have to tell me. Insulin will cross the placenta. Yes or no? Yes or no? Insulin will cross the placenta. Yes or no? Insulin will never ever cross the placenta. So that is the reason here the insulin is drug of choice in the overt diabetes mellitus, and the drug of choice for gestational diabetes mellitus also, and insulin only, because insulin will not cross the placenta. So now tell me, a heparin will cross the placenta or not? Yes or no? Heparin will cross the placenta. Yes or no? The answer is no. Heparin will also not crosses the placenta. So that is the anticoagulant of the choice in a pregnancy. Anticoagulant of the choice in the pregnancy is, so that is heparin, right? Yes sir. So now tell me, warfarin will cross the placenta or not? Warfarin will cross the placenta or not? Yes. Warfarin will cross the placenta. Yes. So then what is the congenital anomaly formed by the warfarin? What is the fetal anomaly or the congenital anomaly is generated due to the intake of the warfarin during the pregnancy? So that is the nasal hypoplasia is the very important one. Nose will not develop, and the most importantly epiphyseal plate of the bone is also goes under development, and that is the, yes. So the two very important one, the epiphysis of the bone will not develop properly, and most importantly the nasal hypoplasia will happen as a teratogenic effect of the warfarin. Okay, yes. So the very important, remember the golden points, insulin and heparin will not cross the placenta. Okay, insulin is the drug of choice in the gestational diabetes mellitus, and the Heparin is the drug of choice in the and or we can say anticoagulant of the choice in the pregnancy. Okay, so I hope it is very much clear. Yes, sir. So now I told here, whenever the patient will come with overt diabetes mellitus, no role of the diet and exercise, directly we are going to start the insulin. Okay, and insulin dose we are need to increase. So when we need to increase, that is in the second and the third trimester we are going to increase. Okay, yes, sir. So now we will discuss about the GDM. What is the GDM? Gestational diabetes mellitus. So the first step in the treatment of the GDM is, so that is first modify the diet of the woman and try to teach the exercise to woman. And here the 90% of the woman will control their blood glucose level by just diet modification and the exercises. The remaining 10% of the women are requiring the treatment. Okay, so the first step in the management of the gestational diabetes mellitus is diet modification and exercise. When this diet modification and exercise, what we can say, a medical nutritional therapy. So when this one will get fail, so then only if the medical nutrition therapy is got fail, then we are going to start the insulin. So I hope it is very much clear. In over diabetes mellitus, no role of the diet and exercise. Over diabetes woman, directly insulin. In the GDM, in the gestational diabetes mellitus, first diet modification. If it fails, then insulin. So I hope it is very much clear. Right. The next question comes here in front of you. Okay. Read the question carefully, correctly, properly, perfectly. Then try to give the best answer for this question. Which of the following statement about the glucosuria in pregnancy is correct? Option A is telling that. Option A is telling that glucosuria in pregnancy is always pathological. No, sir. Glucosuria in pregnancy is not pathological. It is in the physiological. It is in the physiological. It is not a pathological. And it indicates the gestational diabetes. No. Always presence of the glucosuria is not an indication of the GDM. Okay. Yes. So I am eliminating the option A. Then comes to the option B. Glucosuria in pregnancy is never seen and should be investigated immediately. So it is asking it is telling that the glucosuria in pregnancy will never be seen. No, the glucosuria will be in pregnancy may always be present. So this is like it is not in the pathological, it is in the pure physiological. Sir, how it is physiological? You know, in all the pregnant months, placenta will be there, HPL secretion will be there, and insulin resistance will be there. So because of that insulin resistance, glucosuria in pregnancy is normal. Glucosuria in pregnancy is a normal finding, and glucosuria in pregnancy is in the physiological. It is not a pathological. Okay, it is the physiological. So two words I want to tell you is that proteinuria in pregnancy is pathological. It means presence of the protein in the urine. So that is the proteinuria is a pathological, and proteinuria indicates there is in the pre-eclampsia or eclampsia. Okay, and glucosuria in pregnancy is physiological and it is normal. So I hope it is very much clear. Okay, so I hope it is very much clear to everyone of you, right? Yes. So this is the most important thing you are going to keep in your mind. Glucosuria in pregnancy is normal finding, and proteinuria in pregnancy is the pathological. Glucosuria in pregnancy is normal. It is happening due to the resistance against the insulin by the human placental lactose hormone. So I hope it is very much clear to everyone of you. Okay, yes. And proteinuria indicates there may be on the damage to the glomerular membrane. Okay, so that will be seen in the excessive high blood pressure during the pregnancy, and along with that one, proteinuria is also present, means that is the pre-eclampsia. Okay, yes. So now the next question is here in front of you. So please do read the question carefully, correct, proper, perfect, and to give the best answer in the comment box. Question is related to the glucose tolerance test, or we can say the glucose challenge test also. Okay, so which of the following statement about the glucose tolerance test? Okay, so regarding the glucose tolerance test, so which of the following statement in a screening of the gestational diabetes mellitus is correct? So among given the four options, which of the following statement is correct is the question. Option A is telling that a 75 gram oral glucose tolerance test is done daily No, it is not necessary daily. We will perform this one at the 24 to 28 week as an important first step. Okay, so this is the most important to be keep in our mind. It is not required daily. So then I am eliminating the option A. And in some guidelines says we can perform in the first visit also, but if even if you are performing the first visit, but we need to repeat it at around the 24 to 28 week. Okay, so even you are performing in the first visit, so that is working, that is good, that is fine. So still, even if the first visit, like a first visit in the 12th week or before the 12th week happened, you consider that time OGTT have been done, so that is normal. It doesn't mean that the next value also will come normal. Okay, so even if you perform before, so once you must should perform in this particular 24 to 28 week. But why, sir? Why? Because why in this particular week only? Why? Because here there is the maximum resistance against the insulin by the human placental lactose. It will show the maximum resistance against the insulin. So that is the reason we must and should repeat the OGTT or the oral glucose tolerance test at the 24 to 48 weeks. It is not required daily. So I am eliminating the option A. So then comes to the B. Only 1 hour glucose value is measured in a 75 gram OGTT is the question. So here we are not measuring only 1 hour glucose value. So here we are measuring the 2-hour glucose value. So that is after giving the 75 gram of the glucose. You can see how we are going to take the sample. Okay, so sampling how we are going to perform to perform the OGTT. So that is very important for your exam. So please do keep in our mind. So that is, first we will take the fasting blood sugar of the mother. Okay, so this is fasting blood sugar we will take. Then after this one, we are going to give the 75 gram oral glucose in 300 ml of the water we are going to provide. Then we will take the 1 hour sample. Then we are going to take the 1 hour sample. Then we are going to take the 2 hour sample. Means total how many time we need to prick? We need to prick at least of the 3 times. One is for the fasting blood sugar, we need to prick. One for the 1 hour sample we need to prick, and another one is for the 2 hour sample we need to prick. Sir, among this one, which one is the most authentic to like interpret the value? So that is the 2 hour values are very important. Okay, yes sir. So most importantly, please do keep in our mind. So once we will give the 75 gram of the oral glucose level, after the 2 hours we are going to perform the we are going to give the sample, then the result will come around that one. Okay, so now you can see the procedure we have here. That is the a pregnant woman is coming to the OPD. So here we are performing the oral glucose tolerance test or the oral glucose challenge test. Okay, so here we are giving the 75 gram of the glucose orally plus 300 ml of the water. Okay, yes sir. So then we are going to wait for the 2 hours. Okay, so then we will take the sample. Then we will estimate the blood glucose level. So if the blood glucose level is coming less than 140 milligram per deciliter, that is absolutely normal. That is no problem. Between the 140 to 200 milligram per deciliter is the blood glucose level. That is, we can say the gestational diabetes mellitus. And blood glucose level is more than 200 milligram per deciliter. So this is on the overt diabetes mellitus. Very simple. What we are going to do? So we are going to give the 75 gram of the glucose with the 300 ml of the water. We are going to take a 1 hour and a 2 hour sample. So that is a second hour sample. We are going to interpret based on the second hour sample. So that is the blood glucose level to be estimated from the after the 2 hours. We can say the blood glucose level is less than 140, means it is absolutely normal. 140 to 200 is the GDM. More than 200 is the overt diabetes mellitus. So this is important for the exam. So option B is telling only 1 hour we will take. No, we will take the most authentic one after 2 hours. Okay, so that is eliminating option B also. Then comes to the option C. A 75 gram of the glucose tolerance test is typically performed between the 24 to 28 week of the gestation. Yes. So we are going to perform this one typically at the 24 to 28 week of the gestation, because in this time only maximum insulin resistance is there by the human placental lactogen. So that is very important. Please do keep in our mind. Then comes to the option D. GTT is not used for the diagnosis of the GDM, only for the type 2 diabetes mellitus. So no, it is not in the correct statement. So I'm eliminating the D also. Then option C goes to the correct answer for this question. And who all are mentioned the C. So I'm very proud of you. So the interpretation is the very important for your exam. So the blood glucose level after 2 hours of the having the 75 gram of the glucose. So if it is less than 140, that's very nice. That's very normal. If it is the 140 to 200, that is the GDM. This indicating the GDM. And if it is more than 200, that indicating the most important over diabetes mellitus. So please do keep in your mind. These are important for the exam. Okay. So here it comes to the next question. Next question. A 4-month pregnant woman is there, so she is asking which is the best test to predict the risk of the congenital malformation in a fetus of the mother with the gestational diabetes mellitus. So mother is having the diabetes during the pregnancy. So among the given which of the 4 options, so which test we are going to perform to predict, not to detect. Okay, so to predict the risk of the congenital anomaly. So which test we are going to perform? Yes. So congenital anomaly happens in which trimester? Which trimester there is highest risk of the formation of the abnormal organs genesis? Yes. So in which phase it is organs are forming, in that phase only there is chance of the abnormal organogenesis. So that is the congenital anomalies we can say. So in which phase? So that is in the first trimester, all the organs will develop. So during that time, if something is went wrong, so all organ may develop abnormally. So the congenital anomalies may happen. Okay, yes. So here the 4-month pregnant woman is now asking. So she is a 4-month pregnant woman. So now she is asking which is the best test to predict, not to detect. Okay, the risk of the congenital anomalies in a fetus who is having the diabetes in the mother. Okay, so you can see, we can say the very important thing, the only one word. So this is consider the entire length of the pregnancy. Okay, entire length of the pregnancy you consider. And now she's at the 4th week. She's at the 4th month. Okay, right? Yes, sir. So this previous one is the first month, second month, and third month. So we can say the first trimester. Okay, yes, sir. If she maintained the good good glycemic control or the good blood glucose level control is there in this particular first 3 months, means there is very less risk of the congenital anomaly. If she have not maintained the blood glucose level in her first 3 months, means so she have there is no controlled blood glucose, there is an increased blood glucose spikes are there. Okay, so in these first 3 months of the pregnancy, means there is high risk of the congenital anomaly. So now she is 4th month. Okay, now she is 4th month. Okay, so she is asking which one is best to predict. So here we are going to check the last 3 months blood glucose level. Last 3 months, how she was maintaining the blood glucose level, we are going to check here. Okay, so if we are getting the high value, so that indicates the high risk of the congenital anomalies. If we are getting the normal values, so that we will get the low risk of the congenital anomalies. Okay, so most importantly, now you have to tell me, so which test will help us to know the last 3 months or the last 90 days blood glucose level. So that is the HbA1c is the test. So this is helpful for the identifying the last 90 days or the last 3 months blood glucose level. Okay, so in the last 3 months she have not maintained it properly, so the abnormal high blood glucose levels were there, so that is the high risk, and she maintained it properly, so that is very low risk. Now we are performing the HbA1c test. In the HbA1c test, you can see HbA1c test which we are performing here. If the HbA1c value is coming less than 6.5 in a first trimester, so that indicates the less chance of the congenital anomaly, because it will come less than 6.5 when she will, or when the mother will control the blood glucose level perfectly. If the blood glucose level coming more than 6.5, so that indicates that she have not taken the proper treatment, she have not controlled the blood glucose level properly in the last 3 months. So there is no proper control of the blood glucose level, means the high blood glucose level. High blood glucose level means high risk of the congenital anomaly will be there. So to predict which test is best, to predict the HbA1c is best. Okay, so that is the HbA1c in the first trimester is high, means so that we can say there is the high risk of the congenital anomaly. If in question they are asking the best radiological test or the best test to detect the congenital anomaly, so this is best test to, this is the best test to detect congenital anomaly. Okay, so this is very important, so we are going to keep in our mind. Okay, yes, so this TIFA is the best test to detect, and examiner is asking best test to predict, that is the HbA1c. Okay, this is best to predict. Okay, yes sir, so this is very important thing to be keep in our mind. Okay, yes sir. Then option B is the oral glucose tolerance test at the 24 week to 28 week. This will tell whether the woman is having the like no diabetes or the gestational diabetes or the overt diabetes, so that OGTT will tell. Okay, so that is not in the best test to predict. Then the fasting blood glucose in the third trimester is not going to helpful, so the remaining options are just in the derivative, and the answer for this question goes to the option A, because in the question the examiner asked which one is the best to predict. Okay, so I hope it is very much clear. The next question is here, so you can see the a very important table. So this is most important for your exam. So now you have to tell me, I will ask one question, so you have to mention the answer in a yes or no format. Okay, so in both gestational diabetes mellitus and the overt diabetes mellitus cases, is there any equal chance of the getting the congenital anomaly? Is there any equal chance or the not equal chance? If equal chance, you mention yes. If not equal, you mention no. Yes, is that risk of the congenital anomaly in the overt diabetes mellitus and the gestational diabetes mellitus, risk is same or different? If same, mention yes. If different, mention no. Yes, the answer is no, because in the gestational diabetes mellitus, risk of the congenital anomaly is very less, very less. But in the overt diabetes mellitus, the risk of the congenital anomaly is very high and very high. Sir, how, sir? Both are in the both the situation blood glucose level is increasing, and in the both the situation the mother is pregnant, so baby is there inside. Sir, why then? Why in the overt diabetes mellitus high risk of the congenital anomaly, and in the GDM low risk of the congenital anomaly? Sir, why? What is the reason? Understand. So in the gestational diabetes mellitus, what happens? The blood glucose level is increasing after the 24 weeks, right? Yes, sir. So it means in the first trimester of the pregnancy, the blood glucose level is normal. Okay, so in the first trimester of the pregnancy, blood glucose level is normal. It means during the organogenesis, blood glucose level is normal. So there is no any effect on the organogenesis. There is no any effect on the organogenesis means very low chance of the congenital anomaly. And there is no impact on the organogenesis means there is no risk of the first trimester abortion in the GDM. And after the 12 week of the pregnancy, the blood glucose level is coming back to the normal in the gestational diabetes mellitus. But it is not like this in the overt diabetes mellitus. In the overt diabetes mellitus, before the pregnancy also high blood glucose level, and first trimester, second trimester, third trimester of the pregnancy also high blood glucose level, and after the pregnancy also high blood glucose level. And most importantly, in the first trimester, the organogenesis is happening. So during that time also there is the high blood glucose level. So the organogenesis may hampers, organogenesis may get disturbs, and there is in the chance of the increased risk of the congenital anomalies. So increased risk of the congenital anomalies. And most importantly, so if the congenital anomalies are there means the first trimester abortion will happen, because the most common cause of the first trimester abortion is the congenital anomalies. Okay, so please do keep in our mind. So that is the chromosomal abnormalities will be there. So that is because of the any congenital defects. Okay, so that is the most important. Next comes to the, and in the case of the overt diabetes mellitus, after the pregnancy, blood glucose level will not comes back to the normal. Okay, so after the pregnancy, it will not come to the normal. So in the GDM, after completion of the pregnancy, it will comes to the normal. So I hope it is very much clear. The simple concept what I want to explain is, in the overt diabetes mellitus, before pregnancy, first trimester, second trimester, third trimester, after pregnancy, all time blood glucose level will be high only. So all time high means in the first trimester also it is high. In the first trimester it is high means there is in the impairment in the organogenesis, and there is in the problem in the organogenesis. Organogenesis is the problem, which means in the organogenesis the problem is there, which means the congenital anomalies or the chromosomal abnormality risk will be very high. Okay, so which will cause the first trimester abortion also in the ODM. But in the GM, that is the GDM, in the gestational diabetes mellitus, only and only blood glucose level is increasing after the 24 weeks, and most importantly in the first trimester there is completely and absolutely normal blood glucose level. Normal blood glucose level in the first trimester, which indicates there is a very low risk of the chromosomal abnormalities and congenital anomalies, and there is no risk of the first trimester abortion is there in the GDM. So that is the very, very important we are going to keep in our mind. Okay, here it comes to the next question. What is the most common congenital malformation in the fetus of the mother with a gestational diabetes mellitus? In a fetus with a mother of gestational diabetes mellitus, which one is the most common congenital malformation is the question. Yes, try to give the best answer. What is your best answer for this question? Whether it is a neonatal defect, or it is a cardiac anomalies, or whether it is the renal agenesis or the limb deformity. So what is your answer? Yes. Well done. So that is the cardiac anomalies. Cardiac anomalies are the most common congenital anomalies in a fetus who born to the mother with a gestational diabetes mellitus. So these golden points are important for you. So please do keep in our mind. The most common organ system, the risk of the, you can note the headline here, risk of the congenital malformation in the baby of the diabetic mother. In a baby of the diabetic mother. So the most common organ system involved in the baby of the diabetic mother is, first answer goes to the cardiovascular system, and the second priority go to the central nervous system. And most common congenital anomaly happening which one? So that is most commonly involved organ system is the our cardiovascular system, means the most common congenital anomaly is also related to the cardiovascular system, right? Sir, what is that one? That is the ventricular septal defect is the most common congenital anomaly associated with the gestational diabetes mellitus. And the second one is the, so second most common type of the organ system involved in the central nervous system, and here the second one, the most common congenital anomalies is the, that is the second most common is the neural tube defect. First most common is the ventricular septal defect. I hope it is very much clear to every one of you. And if someone is asking the question, the most specific congenital anomaly, so most specific is the sacral agenesis or the CRS, that is the caudal regression syndrome. So caudal regression syndrome or the sacral agenesis are the most specific congenital anomalies, and most common congenital anomalies are the ventricular septal defect is the first priority, and the neural tube defect is the second priority. And the most common organ system involved is, the first priority goes to the cardiovascular system, and the second priority goes to the central nervous system. So I hope it is very much clear to every one of you. Okay, and here it comes to the next question. So please do read the question carefully, correctly, properly, perfectly, then try to get the best answer. But do mention your answer. Which of the following is the most common complication associated with the gestational diabetes mellitus in a mother except one? So in a mother, what is the most common complication? So now we are discussing the most common complications or the common complications which is associated with a mother, which is associated with a fetus, which is associated with a newborn. So three very important categories we will study: the complication in the mother, complication in the fetus, complication in the newborn. Okay, so now you have to tell me, so that in a mother, fetus, newborn, to whom we are going to check the blood glucose level for the hypoglycemia. Yes, in the last class we have done this already. Yes, to whom we are going to check the hypoglycemia, to mother or to the fetus or to the newborn? To whom? To whom? So yes, to the newborn we are going to check for the hypoglycemia. Sir, how means? Very simple. In the last class only we have done, that is the consider she is on the pregnant woman. Okay, so she is on the pregnant woman. Inside this pregnant woman there is on the beautiful baby, that is called as the fetus. Sir, what is the fetus? Fetus is on the after the fertilization. So there is on the time period is there. So from particular time period to the till the birth, so that is called as the fetus. So when to when we call the fetus? Yes, at what time to what time we call as the fetus? What anyone? Yes, what is the criteria of the fetus? What is the criteria of the embryo? Yes, what is the criteria of the newborn? Anyone? What? Yes, the fetus is from the is from the 8th week of the gestation, or we can say after completion of the 8th week. So that is from the 9th week to till the birth. Okay, till the birth. So this one is called as the fetus. Now tell me, birth to first 7 days, what we can call? Birth to first 7 days of the life, what we can call? Yes, this is called as in the early neonate. What we can call? We can call this one as the early neonate. Okay, very perfect. So from the 7 days, from the 7 days to till the 28 days of the life, what we can call? So what we can call? 7 days to 28 days of the life. So what we can call? Yes, so that is in the late neonate. Okay, so late neonate, most important. So understand this term. So from the birth to the 9 weeks, so 9 week to the birth, that is the fetus, and from the birth to the 7 days is the early neonate, and from the 7 days to the 28 days is the late neonate. Okay, so then what we call from the 2 weeks to 8 week, what we call this one? 2 week to the 8 week. Yes, 2 week to the 8 week we call this one as the, yes, that's called as the embryo. Okay, so this is in the embryo phase. Okay, so after the fertilization, from the 2 weeks to the 8 weeks, we call this one as the embryo. Okay, so yes, and from the day 1 of the fertilization, or from the 0 to the 2 weeks, or we can say 0 to the 14 days of the life. So what we can say? 0 to 14 days after the fertilization, what we can say? Yes, we can say to this one as in the a fertilized ovum. Okay, so what we can say? This is in the fertilized ovum, right? Yes, so this is on the embryonic developmental phases. Okay, that is from the 0 to 2 weeks, or the 0 to 14 days is the ovum, and the fertilized ovum, what we can say, and 2 weeks to 8 weeks is the embryo, and the 9 weeks to the birth is the fetus, and birth to the 7 days is the early neonate, and the 7 days to the 28 days is the late neonate. Very perfect, very interactive. Okay, so that's very perfect. Now you tell me, so this one is from the 9 week after fertilization to the till birth. So the a baby is there inside the mother womb only. So that is what you can call the fetus. Okay, so now in the gestational diabetic mother, so this is completely the mother will be filled with the glucose. Okay, so because the mother is having the gestational diabetes, so in her the blood glucose level is high. So the same blood glucose level will comes to the fetus. So the high blood glucose level means the more blood glucose level come to the fetus also. Now fetus is getting the more blood glucose level, right? Yes, sir. In response to this one, the fetus will start to produce the more insulin. Okay, so fetus will start to produce the more insulin is keep on producing by the fetus. Okay, yes sir. So now the mother is having the increased blood glucose, that is the hyperglycemia is there, and the fetus, it is also having the increased blood glucose. Yes sir. So now once after delivery of this particular fetus, this fetus will comes out, right? Yes sir. And the supply which is their umbilical cord, we will cut after the birth, right? Yes sir. So here the insulin keep on producing, and blood glucose level supply is decreased. So sudden stoppage of the blood glucose supply and the insulin is keep on producing means, so in this particular newborn, what happens in particular newborn, the hypoglycemia happens. Okay, yes sir. So the question will come straightforward. So what you are going to assess in a newborn with a gestational diabetes mellitus? So in a newborn of gestational diabetes mellitus, we are going to monitor for the hypoglycemia. Okay, in the fetus hyperglycemia, in the mother hyperglycemia, but in the newborn it is in the hypoglycemia. The classical question where the examiner very frequently ask in your exam. Okay, so please do keep in your mind, right? Is that clear to every one of you? Yes, is that clear to every one of you? Well done. So now comes to the question here. The question is very simple. The common complication associated with the gestational diabetes mellitus in a mother except one. So here are the 4 complication will happens in the mother. Okay, so except one. So which one will not happen here? What? Is that hyperglycemia is happening in the mother? Yes sir. So in the mother there is HPL hormone abnormally, it may increasing means, so which will cause the resistance against the insulin at the 24 to 28 week. So that is the reason hyperglycemia will happen due to the insulin resistance. Yes, it will happens. Then comes to the preterm labor. Is that preterm labor will happen? Yes sir. Sir, how preterm labor will happen? Listen carefully. So here the hyperglycemia is there. Yes sir. You know, wherever there is the increased glucose, there is increased chance of the infection. So there is, because of this particular hyperglycemia, there is high chance of the vaginitis, and most importantly urinary tract infection. These 2 things will be predominant. Okay, so you know the UTI, the asymptomatic UTI also may cause the preterm labor. Okay, so we have studied already. That is the reason in the antenatal checkup, so the clinical urine examination is must, because the asymptomatic UTI is also going to cause the preterm. Because of this infection, the preterm labor may happen. Yes, is that preterm labor will happen or not? Yes, it happens. So this is one reason for the preterm labor. Sir, what is another reason, sir? Yes, you know, if the mother is having the diabetes means, you know, the classical clinical finding of the diabetes, there is the polyuria. Yes sir, polyuria means excessive production of the urine. So wherever the glucose is increasing, so that time the urine production will happen more because of the osmotic diuresis. Okay, so what is the osmotic diuresis? So that is a very simple concept. Here you are going to keep in your mind. So consider this is in the blood vessel. This is in the blood vessel we have. Okay, so inside the blood vessel there is normal blood glucose means that will be a balance. Okay, so now inside the blood vessel the blood glucose is more, you consider. So blood glucose is more, you consider, so the concentration of the blood glucose is more. So now in order to dilute this one, whatever the fluid is there outside the blood vessel, it will suck it inside. Okay, it will suck inside. So when the fluid will come excessively inside, okay, so when the fluid it will comes excessively inside, so there is the more supply of the fluid towards the kidney. So more supply of the fluid towards the kidney means more filtration of the fluid. More filtration of the fluid means more production of the urine. So polyuria will happen. So here this blood glucose which is increased inside our blood vessel, which is sucking the fluid inside the blood vessel. So that is due to the osmosis. Procedure process. So because of this osmosis, the more blood is going towards the kidney and production of the urine. So that is called as the osmotic diuresis. If the question is coming in the exam, which type of the diuresis or which kind of the diuresis happens in the diabetes, so that is your answer should be osmotic diuresis will happens in the diabetic patient you are going to tell. Okay, yes sir. So in the pregnancy induced hypertension, in the gestational diabetes mellitus also, so polyuria may happens. And you know, in a mother the polyuria happens because of the blood increased blood glucose level. Similarly, so when this particular fetus, it was there inside the mother womb, so that time also the fetus was having the more blood glucose level. Okay, so here more blood glucose level means the fetus will form a more urine. So fetus will form more urine means, you know, so fetus is forming the more urine means, so that is the polyuria and the fetus will happens. So urine is the main source of the amniotic fluid. Okay, so urine is the main source of the amniotic fluid. So because of the polyuria, there is in the polyhydroamnios. Okay, so that is in the abnormally increased excessive amniotic fluid. So when the amniotic fluid is more means the uterus will distend. Uterus will distend more. Uterus is distending more means, so early sign like pregnancy, early like labor will begin. So that is the because of the distended uterus, the amniotic sac also will distend more. So the sac which is distended more can rupture also. That's the PROM may happen. So that's the premature rupture of the membrane may happens because of the distended membrane. So that is the very important thing. And here the polyhydramnios means uterus also going to distend more. Okay, so uterus also going to distend more. So you know the uterus distended more means, so one concept is there, so that is already how discussed previously, that is big uterus bleeds more. Okay, so here the uterus distended more, uterus distended more means this is a big uterus. Okay, so this big uterus bleed more. Okay, so this will bleeds more. This bleeds more means there is high risk of the postpartum hemorrhage is there. Okay, yes. So in the due to the diabetes in the pregnancy, PPH will happen or not, sir? Yes, absolutely. Complication of the diabetes in a mother is the, so PPH will happen. Yes, it happens, sir. Sir, premature rupture of the membrane will happens in the gestational diabetes mellitus. Yes, absolutely. The premature rupture of the membrane risk will be high. So when the premature rupture of the membrane will happens means in advanced membrane is getting rupture means, so we can say preterm labor will happens. Yes, sir. Preterm labor will also happens. Yes, yes, sir. And polyhydramnios is happening, sir. Yes, polyhydramnios is happening due to the polyuria in the fetus. Okay, so now you come to the question, that is then the hyperglycemia is happening. Because of the hyperglycemia, there is vaginitis and the UTI may happens. So that may cause the preterm labor, or else due to the excessive production of the urine by the fetus, there is in the polyhydramnios may happens. So this polyhydramnios may cause the premature rupture of membrane. So that may cause the preterm labor. Yes, the postpartum labor will not happen. So in the question what they have asked related to which one is accepted here. Okay, accepted here means, so that is the post-term labor will not happen. Better. So what will not happen? The post-term labor will not happen. The answer for this question goes to the option D, and the rest all are the complication of the complication in the mother with a gestational diabetes mellitus. Okay, so now you tell me one single question I will ask. In a newborn, respiratory distress will happen or not? A baby which is born to the diabetic mother, the chance of the respiratory distress is there or not? Yes, absolutely. Yes, sir. Why? Why? Because you know, due to the gestational diabetes mellitus, the preterm labor is happening. Preterm birth is the most common or the highest risk factor for the respiratory distress. Yes, yes, sir. So in advanced baby born means lungs are immature. Immature lungs means the RDS will happens, right? Yes. So in the newborn, the risk of the respiratory distress syndrome is present. Okay. So I hope it is clear. So can I ask some question to every one of you? So you have to tell me the answer in the yes or no format. Okay, so gestational diabetes mellitus will decrease as the risk of the postpartum hemorrhage? What is your answer? Gestational diabetes mellitus is going to decrease the risk of the postpartum hemorrhage. So is my statement, is this correct or wrong? It is wrong. Okay, so no should be your answer. Okay, yes. I told due to the excess urine production in the fetus, polyhydramnios will happen. Polyhydramnios means the more amount of the amniotic fluid. So means uterus will distend more. Big uterus will bleed more. Risk of the PPH will increases. In a statement, I told decreases. So that is wrong. Okay. Yes. The next question is gestational diabetes mellitus, which leads to the post-term labor. Is this statement is right or wrong? Yes or no? Yes, that is the no. Why? Because the gestational diabetes mellitus will cause the preterm labor, not a post-term labor. Okay. Yes. Gestational diabetes mellitus will increase the risk of the vaginitis and the urinary tract infection risk. Yes or no? Yes or no? Yes, very perfect. Gestational diabetes mellitus, which leads to the oligohydramnios. Yes or no? Yes or no? Perfect. So that is no, because gestational diabetes mellitus, which causing the polyhydramnios, not a oligohydramnios. Okay, yes, very perfect. Then my next question is risk of congenital anomaly in a overt diabetes mellitus is more as compared to the gestational diabetes mellitus. Is this statement is correct or wrong? Risk of the congenital anomalies in a overt diabetes mellitus is more as compared to the gestational diabetes mellitus. Yes or no? Is this statement is correct or not? Yes, this statement is perfectly correct. Why? Because in overt diabetes mellitus, during the first trimester, there is the high blood glucose level that forms the free radicals that forms the more congenital anomalies. In the gestational diabetes mellitus, blood glucose level will increases after the 24-week. Okay, so after the 24-week, blood glucose level is increasing, which means yes. So the first trimester there is no any hyperglycemia, means there is no any free radicals. There is no any free radicals means there is no any free radicals means there is less risk of the congenital anomalies in the gestational diabetes mellitus. Okay, and because of the high risk of the congenital anomalies in the overt diabetes mellitus, first trimester abortion also high risk in the overt, and in the gestational diabetes mellitus, first trimester abortion is the low risk. I hope it is very much clear to every one of you, right? Yes. So I hope it is clear to every one of you. Yes. Next, let me take you to a beautiful ride on the simple words now. So just we have already discussed maternal complication in the gestational diabetes mellitus. Hyperglycemia will happen, and which forms the UTI and vaginitis. So which may cause the preterm labor. And because of the excessive urine in the baby, so there is in the polyhydramnios. This polyhydramnios may ruptures the membrane in advance, so that's the preterm rupture of membrane, so which is going to cause the preterm labor. Okay, and most importantly, so here the polyhydramnios, which means there is in the distended uterus. Distended uterus means the big uterus will bleeds more. Big uterus is bleeding more means there is in the risk of the postpartum hemorrhage is more. So I hope it is very much clear every point. Okay, yes sir. The next comes to the fetal complication. What are the complication happens to the fetus? So mother high blood glucose means same blood glucose will cross the placenta and will comes to the fetus. Yes, the hyperglycemia will happens in the fetus. Yes sir. So next, fetal pancreas will start to produce the more insulin. Yes sir. Why? Because the glucose level is high in the fetus, so the fetal pancreas will start to produce the more insulin. Now tell me, when the fetus will start to produce the insulin, what is the time of the pregnancy, or at which time of the pregnancy fetus will start to produce the insulin? Yes, remember my favorite number, that is the 1 2. Okay, so that's the 1 2 means, so that's the 12 week. So fetus will start to produce the insulin, fetus will start to produce the urine. Okay, yes, so that is the 12 week is the very important point you are going to keep in your mind. Okay, yes, so now here more glucose is coming to the fetus means more insulin production will be there. So you know the main hormone responsible for the growth of the fetus, that is the insulin like growth factors. Okay, insulin like growth factors, in the sense the insulin only we consider just it out. Okay, so there is main important hormone for the growth of the fetus is the insulin, where the more insulin and insulin like growth factor in the baby of the diabetic mother, the more excessive growth of the baby will happens. So that is called as the macro big soma body. So that's the macrosomia will happen. So macrosomia criteria is the birth weight of the baby is more than 4 kg. So we call that as the macrosomic baby. Okay, so in the macrosomia what happens, all the body weight will come and deposit at the shoulder. So head will comes easily out, but the shoulder will not comes easily out. There is in the difficulty in the delivery of the shoulder. So difficulty in the delivery of the shoulder we call as the shoulder dystocia. Okay, so we call this one as in the shoulder dystocia. Okay, so that's a very very important point we are going to keep in our mind, right? Yes sir. So because of this one there may be on the intrauterine fetal death, intrauterine fetal demise, and the stillbirth may happen. Okay, so these are the fetal complications. Okay, next which we have is, so that is the complications in the newborn. Okay, so complications in the newborn happening is the, so that is the hypoglycemia. So this is the very 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 important for the exam, so please do keep in your mind. Okay, so in the mother hyperglycemia is happening, and in the fetus hyperglycemia is happening, but to the newborn what happening, to the newborn hypoglycemia is happening. So why? Because I already told the mother is full of the glucose, so that is in the hyperglycemia. Same glucose will transfer to the fetus also. This is in the fetus. Okay, so this is in the fetus. Now fetus will start to produce the more insulin. Okay, so after the birth what we will do, after the birth we will cut the umbilical cord. Okay, we will cut the umbilical cord means the glucose supply towards the fetus is stopped. Okay, so there is the stop in the glucose supply in the newborns. Okay, so now the fetus which came out of the mother womb means, so that is not a fetus, that is now newborn. Okay, so in the newborn what happening in the newborn, the more insulin is producing by the newborn our pancreas. Okay, so but the glucose supply is stopped, so insulin is increasing and glucose supply is decreasing, so which means there is a high risk of the hypoglycemia, and there is high risk of the hypoglycemia. So what you are going to monitor in the newborn of the diabetic mother, so I am going to monitor for the hypoglycemia. So please do remember the preterm labor is happening in the mother means, so there is in the high risk of the respiratory distress, high risk of the respiratory distress, and the respiratory distress syndrome happens. And what happens to the electrolytes in the newborn, sir? You check for the potassium, you check for the magnesium, you check for the calcium. Everything will be hypoglycemia, hypocalcemia, hypomagnesemia, hypokalemia. So these are the very very important points to be keep in our mind. Okay, so I hope it is clear to every one of you. Fatapat do thumbs up. Is that clear? Is this all the concept are very much clear to every one of you? Do thumbs up everyone. Yes, so the next question comes here. Just in the quick review, that is already done points. Mother hyperglycemia, fetus hyperglycemia, newborn hypoglycemia, already done. The next question is drug of choice for the gestational diabetes mellitus mother is, and drug of choice for the over diabetes mother. What is the answer? Yes, in the both the question is about drug of choice. Yes, that is in the always insulin goes to the priority. Sir, can we use the oral hypoglycemic agent, sir? Yes, we can use the oral hypoglycemic agent. When means when the mother will refuse to take the insulin, that time we can use the only two OGS oral hypoglycemic agents are allowed. So that is the one is Mahatma, another one is Gandhi. Okay, so that is the metformin and glycerides are the only two medicines are allowed. Okay, So but the best is always our insulin is the best treatment, and always the drug of choice is the insulin, because it will not cross the placenta. Okay, so next my question is whether the glucose is going to cross the placenta. Is the glucose is going to cross the placenta? Yes or no? Yes or no? Yes or no? Yes, the glucose is going to cross the placenta. Okay, yes, that is very true, right? So then next my question is whether the insulin is going to cross the placenta. Insulin is going to cross the placenta. Insulin will cross the placenta. No, the answer is no. So that is the reason insulin is the drug of choice in the most important gestational diabetes mellitus. Okay, yes. So dear aspirants, so many people will start to prepare. Many people will start to prepare, but the only champions will finish. And you are the champion, and you are here to win. So how you will begin the thing, that is not going to matter. How you will finish the thing, so that is going to create a history, that is going to reduce your all the backlogs, that is going to reduce all the darkness which is there in the life. So don't be a best beginner, always be a best finisher. So best finishers are the, yes, so you all are the best finishers, because you already have cleared the prelims, and you already in an entry of the mains, and you are going to appear the mains. So how you are going to appear the mains? You are going to appear the mains with the confidence and clarity and concept. So that is, you are going to implement in the exam to get the best rank, and you have to make your master proud. So definitely I am waiting for your best result. So yes, every one of you have to perform very best. So that is, I will pray in the God that all the effort, all the late nights, all the early mornings, what you have awakened and what you have put the effort, each question you have solved with even with the eyes training. So you have done lots of the hard work. Every point of your hard work is going to pay. Just be consistent, confident. So that is only going to create the clarity. So that is only going to create the rank. Okay, yes. So just never give up. Even your prelims also not qualified, never give up. So I told the one word in the initial. Many people will start to prepare, but the few people will finish in their own style. So they become a best finishers. Best finishers are always winners. Okay, so don't expect a success suddenly, except as like you try to feel the success. So when you will feel that your preparation is complete, then you will feel the success. Smell of the success will come automatically when your preparation is in the peak. Okay, so just believe in yourself, dream it, believe it, build it, win it. That's it. Okay, so that is the thing you are going to keep in your mind. Okay, yes, here it comes to the next question. So who all are not qualified in the prelims, go to the A1 plan, learn from the A1 plan. Every concept, like I thought a concept like, I consider my students are just kids, first standard, second standard kids. So how we are going to make them understand, in that way we have written and explained the thing to you. Okay, so try to understand the concept what we have built. So that try to build yourself and win. Okay, so that is the only way to get success. If you are not ready to hard work, don't accept the success. If you are ready to hard work, the success will be yours definitely. Here it comes to the next question. What is the correct definition of the pregnancy-induced hypertension? Yes, so the question is waiting for your brilliant answer. So fatapat, fill the comment box with your complete best answer. What is the correct definition of the pregnancy-induced hypertension? Option A is explaining that blood pressure is more than 180 by 90 mm of Hg before the 20 weeks of the gestation. So this is absolutely an blunder option. You can easily eliminate it, because the blood pressure will increase. Blood pressure will increase, but not before the 20 week of the gestation. It will increase after the 20 week of the gestation. I am eliminating the option A. And then comes to the option B, blood pressure more than 140 by 90 mm of Hg after the 20 week of the gestation without proteinuria. Without proteinuria. So this is in the classical definition of the pregnancy-induced hypertension. Okay, very perfect definition. So I will keep this one, and I will go for the next option. So that is option C. Blood pressure more than 160 by 110 mm of Hg with proteinuria after the 28 week of the after the 20 week of the gestation. So here the BP is crossed more than 160 by 110 and proteinuria is also present, means so this is and the severe kind of the pre-eclampsia. So we can say now the new words. Yes, previously we used to say the severe pre-eclampsia. Now what we are saying, so that is nothing is different here. So that is we are saying that is the pre-eclampsia with severe future, okay. Yes, this is very important to be keeping up, right? Yes, sir. So now the next option D comes here. The blood pressure is more than 130 by 80 mm Hg after 28 week of gestation with edema. So this is previously edema is also in the very important sign we used to consider, but now edema is not in the diagnostic criteria. So just I'm eliminating the option D as well. So then comes to the question. So that is what is the word asked in the question. They have asked that correct definition of the PIH. PIH definition goes to the option B. Okay, so option B is the correct answer for this particular question. So I'm marking it round and this. Okay, yes. So I hope it is very much clear. We can see the criteria of the PIH. What happens when we will check the blood pressure before the 20 week? Before the 20 week, blood pressure in the woman is absolutely perfectly normal. And after the 20 week, what happens? Due to some problem in the placenta, PIH, preeclampsia, eclampsia. These all are a problem of the placenta. And definitive management of the PIH, preeclampsia and eclampsia is delivery of the placenta. So that is the very important. Definitive management of the preeclampsia, eclampsia and pregnancy-induced hypertension. So that is the you remove the cause. So the problem is there in the placenta. So you remove the cause. Okay. So that is the definitive management of the PIH, preeclampsia and eclampsia. That is the delivery of the placenta. Okay. Yes. Before the 20 week, absolute normal BP. After the 20 week, due to the problem in the placenta, the BP is gone more than 140 by 90 mm per G. Sir, is that one time is enough? No, it is not enough. So we need to check the 2 times at least. Sir, what is the gap between the first and second reading, sir? At least with a 4-hour gap we are going to check. Okay, yes. After the 20 week, due to the problem in the placenta, BP is more than 140 by 90 mm per G in 2 separate occasions with a 4-hour gaps with no proteinuria. So this is called as the pregnancy-induced hypertension. This is called as the pregnancy-induced hypertension. If with proteinuria, we call that is the preeclampsia. Okay, yes. So the high BP without proteinuria is the PIH. High BP with proteinuria is the preeclampsia, and high BP proteinuria plus seizures. So that's the eclampsia. Okay, is that clear to every one of you? Yes. Is that clear to every one of you? So you are you ready to tell the definition? The blood pressure of the woman is more than 160 by 110 mm of Hg. Proteinuria is present and woman is started to throw the seizures suddenly now. Is this what case is this? Option E is the PIH, B is the preeclampsia without severe pictures, C is the preeclampsia with severe pictures, D is the eclampsia. The question is, a pregnant woman is having the BP more than 160 by 90 mm of Hg and proteinuria is also present, and now she is suddenly started to throw the seizure. What case is this one? So that is the case of eclampsia. Okay, so because high BP is there, proteinuria is there, and plus seizures are there. Seizures are present means, so that is the epilepsy is present means we call that one as the eclampsia. Only high blood pressure and proteinuria is there. So what is that? That is the preeclampsia. Okay, and only high blood pressure is there. There is no any proteinuria. So that is the pregnancy-induced hypertension. I hope it is clear to every one of you. Is that clear to every one of you? Yes. So the most important word you are going to understand now is the 2 situation again here. So how we studied the diabetes mellitus? 2 situation, that is already a diabetic lady, she got pregnant, that is we call as the overt diabetes mellitus. And one lady, she is absolutely having the normal blood glucose level before the pregnancy, and first 24 week of the pregnancy normal blood glucose. After the 24 week, blood glucose level increased due to the resistance against the insulin by the human placental lactogen. So that is what we call as the gestational diabetes mellitus, right? So here also we have the two situation. One situation is that is already woman is having the hypertension. So this hypertension present woman or the hypertension present mother, she got pregnant now. Okay, so previously hypertension is there, so that hypertensive woman is got pregnant now. So for this case we call as the chronic hypertension in pregnancy. What we can call this one? We call this one as the chronic hypertension in the pregnancy. Okay, yes. So another lady, so this is, she is a normal lady. So before 20 week of the, or the first 20 week of the pregnancy, absolutely normal BP. Before the pregnancy, normal BP, but after the 20 week, due to the problem in the placenta, there is high BP. We call her as the pregnancy-induced hypertension case. Okay, yes, sir. So now you tell me, there is a word we used to read previously. So how this blood pressure is increasing after 20 weeks? So within how many weeks it will come back to the normal? This is the update. So please do write it out. Update. I already have discussed that one in the update session. This is the update. Yes, within how many weeks it will come back to the normal? So if it is in the 12 week in your notebook, so you please do change that one now, and you write that one as a 6 week. As per the FOXY guidelines 2026, that is our Indian guidelines, which is saying that the blood pressure which is increased, so that will comes back to the normal, within 6 weeks. Okay, that will come back to the normal within 6 weeks. Okay, so this is very, very important. Back to normal after the delivery, that is within 6 weeks. Okay, so this is very, very important. We must and should keep in our mind. Okay, yes. So previously that was the 12 week. Now it is the 6 week. If still persisting more than 6 weeks, we can say that is again the chronic hypertension in the pregnancy. Okay, so after the delivery, the blood pressure should come back to the normal within 6 weeks. Okay, if it is persisting behind the 6 weeks, that is also we call as the chronic hypertension in the pregnancy. Okay, yes, sir. So that is, I hope it is clear to every one of you. So then we have the two very important differentiating features you must and should know here. So that is the pregnancy-induced hypertension and preeclampsia. How we are differentiating? Already we have done. That is the hypertension in the pregnancy. PIH is there, so we also call that BP is more than 140 by 90 mm/Hg, but no proteinuria. But in the preeclampsia, BP is more than 140 by 90 mm/Hg, but proteinuria is present. Okay, so here high BP, no proteinuria is the PIH, and high BP and with proteinuria is the preeclampsia. Very simple. Okay, so this is how we are going to differentiate, right? Yes, the next concept is here and question is here. So you have to tell the answer for this particular question. Which of the following is a sign of the end organ damage in a preeclampsia with a severe picture? Except one. So what are the signs of the end organ damage is there in the preeclampsia with severe picture? Preeclampsia with severe picture in the sense the severe preeclampsia. Previously we have the two words, that is the mild preeclampsia, severe preeclampsia. Now we have the two words, that is the preeclampsia with severe pictures and preeclampsia without severe picture. Preeclampsia without severe picture means that is the mild preeclampsia only, and preeclampsia with severe picture means that is the severe preeclampsia. Okay, so just there is change in the word. Okay, don't get confused. Preeclampsia with severe picture means that is the severe preeclampsia. Okay, so in the severe preeclampsia, what happening? Sign of the end organ damage is happening. Okay, yes. Which of the following is a sign of the end organ damage in the severe preeclampsia? Except one. Yes. Option is telling that the serum creatinine more than 1.1 milligram per deciliter. B is visible disturbance, C is pulmonary edema, D is increased platelet. So except one, all are the sign of the our sign of end organ damage except one. Which one? So that is the answer goes to the option B. Sir, how we are going to remember the sign of the end organ damage? So that is very simple. You have to draw a doll like this. Okay, you have to draw a doll like this. Just draw a doll like this. And first one foremost thing, that is the we will start from the top only. That is the at the top what we have. So we have the brain. Okay, so inside the brain what happens? There is in the a fluid will accumulate. So there is a cerebral edema will happen. Okay, so cerebral edema is there means headache. Headache. This is happening due to the cerebral edema. So this is will be seen in the end organ damage. Okay, so because of this cerebral edema, there is in the headache also will happens, and along with this one, here we have the eyes. Because of this cerebral edema only, there is in the visual disturbance will happen. There is in the visual disturbance will happen. Okay, yes. So after that, what we have? We have the a mouth. So nothing will happen to the mouth. Then comes to the lungs. Then comes to the lungs. In the lungs, what happens? The pulmonary edema will happen. Pulmonary edema happen means so there is a difficulty in breathing, so that all things will be there, desaturation and all. Next, which we have the very important organ, that is the liver. That is the liver. Okay, so here in the liver, what happens? All the liver enzymes becomes double due to the damage of the liver. Okay, so liver enzymes more than 2 times. Okay, more than 2 times of its normal value. Then comes to the after liver, which we have, that is we have the kidney. Okay, so what we have after the liver, we have the kidney. Okay, so the kidney is got damaged means what happens? The creatinine level. Okay, so creatinine level will be going to increase. That is the more than 1.1. Okay, yes, so this is the very important. More than 1.1 milligram per deciliter creatinine level is also going to increase, right? So there is the cerebral edema. Due to the cerebral edema, headache is happening and visible disturbance is happening, and pulmonary edema is happening. Liver enzymes are got double, and the creatinine is more than 1.1. And remember, there is the decreased platelet also. There is the decreased platelet also. Okay, so decreased platelet in the sense the thrombocytopenia is happening. Thrombocytopenia is not happening, and here in the increased platelet mentioned. So this is actually wrong. Okay, so this is actually wrong. You can see serum creatinine is increased. Yes, due to the kidney damage. So here is the creatinine more than 1.1 milligram per deciliter. Then due to the cerebral edema, visible disturbances there, and here the pulmonary edema is there. So but the increased platelet will not be there. So there is the decreased platelet except one means. So we need to choose the correct answer. That is the increased platelet. Okay, so these are the sign of the end organ damage. So we have to keep in our mind. So we are using this is the premolatory symptoms of the preeclampsia. Okay, so that is the severe preeclampsia premolatory symptoms. Okay, so that's the premolatory symptoms. Okay, so this premolatory symptoms also we can say, or we can say as the sign of the end organ damage. I hope it is very much clear. Is that clear? So the same doll I have made here. So that is the forever quick revision. We can take it out. Okay, so same to same what we have discussed above. But the next one is here. Which of the following is the common sign of the impending eclampsia in a woman with the preeclampsia? So now you tell me, what is the preeclampsia? What is the eclampsia? So just we have discussed that is the a high blood pressure with proteinuria is the preeclampsia, and high blood pressure plus proteinuria plus seizures, that is the eclampsia. So here what happens, before converting the preeclampsia to eclampsia, So there are some warning signs will comes. So those warning signs we call as the sign of the impending eclampsia. Okay, so what we can call that one is the signs of the impending eclampsia, right? Yes, sir. So which of the following is the common sign of the impending eclampsia in a woman with a preeclampsia is the question. Option is the mild ankle edema. Mild ankle edema is the physiological. It is in the normal. Okay. If the suddenly puffiness of the face is happening and suddenly fingers are got swollen where the finger is like finger ring is unable to remove, and suddenly below the ankle also there is in the edema, suddenly dyspnea is formed, gastric irritation have been started suddenly, so that all indicates there is in the a sign of impending eclampsia. So ankle edema is normal. Okay, so sudden puffiness of the face and sudden swelling of the hands, so especially fingers where we are unable to remove the finger ring. Okay, so these all are the a sudden massive edema, so that is abnormal. Okay, yes, so mild ankle edema is normal, so this is not in the sign of the impending eclampsia. Then the sudden weight loss, no better, when there is in the edema is happening in the whole body in the preeclampsia and eclampsia, so which will causes the weight gain because of the proteinuria. Because of the proteinuria, the loss of the protein, like excessive loss of the protein will happens. Protein is lost means edema will happens. Edema is happening means weight gain will happens. So weight gain happens, not weight loss. So this is not in the sign of the impending preeclampsia. So sorry, it is not a sign of the impending eclampsia. Eliminating the option B also. Then comes to the option D. There is a fetal bradycardia, completely unrelated word. So there may be a fetal tachycardia we may see. This is also not a sign of the impending eclampsia. Yes, very nice. Every one of you have given the best answer. That is the persistent severe headache with the visual disturbances. So this is in the sign of the impending eclampsia. So what is the sign of the impending eclampsia? You can see. So first and foremost, there is maybe a preeclampsia with severe pictures. There is the severe picture in the sense there is damage of the end organs. So that is what you call the preeclampsia with the severe pictures or the premonitory symptoms. Okay, yes. So this preeclampsia anytime may get converted into a seizure, and if the preeclampsia patient is having the seizure, we call that one as the eclampsia patient. Okay, so this preeclampsia anytime may throw a seizure and which may get converted into the eclampsia. So that is the reason whenever we will admit the preeclampsia patient with severe pictures, where we will admit this patient in the low stimulating room, where the cool, calm, relaxed room, which like there should not be any bad smell, there should be a proper ventilation, and there should not be any sudden dark light. Okay, sorry, there should not be any sudden bright light, and there should not be any sudden sound. In that particular area, we are going to admit the preeclampsia with severe picture patient, because this preeclampsia patient anytime may get converted into the eclampsia, means anytime may get converted into the seizures. So in order to prevent the seizure, we will keep the woman in the non-stimulating environment. Okay, so if this preeclampsia with severe picture woman may get converted into seizures, before converting she will show some warning signs. These warning signs only we call as the sign of the impending eclampsia. Means if these warning signs are present, we may suspect a woman may going to show the seizure symptoms very soon. Okay, yes. So what are the warning sign or the sign of the impending eclampsia? So that is in the first one will be the headache which is not relieved by the usual treatment. So we are giving the headache. So that is again we will start from the top. Headache will be there, so that is not relieved by the usual treatment. Usual treatment is going on, so that is like NSAIDs, painkillers are going on, still it is not relieved. And the visual disturbances again, and the epigastric pain, and the urine output less than 30 ml per hour. Okay, so these all are the sign of the impending eclampsia. Okay, so in a severe eclamptic patient, sudden urine output is decreased less than 30 ml per hour, which indicates a woman may get show into the symptoms of the eclampsia. Okay, so these are the important clinical points you are going to keep in your mind. Okay, so I hope it is very much clear. Is that clear to every one of you? What is the sign of impending eclampsia and the warning signs of the conversion of the preeclampsia with severe features to the eclampsia? Is that clear to every one of you? Yes, the perfect. Next question comes here. Very important. According to me, a 10 star and more than 10 star question. Try to give your best answer. Take a 2 to 3 minutes of the time. Take a 10 minutes and 1 hour of the time after the class if you want. Now you take the 30, 60 second of the time and give the best answer. Okay. So I will wait maximum 60 seconds, not more than that. Okay. So in exam also you will be getting that one, not more than that. Okay. So try to give the best answer. Which of the following correctly describes Pritchard regimen of the MGSO for administration in the eclampsia? Yes. Candidates who are preparing for the Norcet 11 exam, so very frequently you guys are messaging like, sir, how to study, how to study, how to study. So just we have the little bit responsibility till the 30th of the this particular month, because we have the lots of the candidates in our hands who are going to attend the mains exam. We are completely focusing on them, and immediately after completion of the mains, next day only your special training will start. That training will go into such a next level, and in every step of your confusion we will be there, even every step of your clarity we will be there, and we will be there to build the confidence along with the topic clarity, and we will definitely push you inside the selection list. So that is with our help of our quality content. If you are ready to work hard, join now. There should not be any delay. Okay, so don't worry, next day after the mains we will take a special training, and that is going to be a game changer in your life. Okay, yes, well done. So answer for this question goes to the option C. Many of you have mentioned that is the Pritchard regimen, which is correctly described here. Is that so? That's the 4 gram of the MgSO4 I am administering. So that is by the IV route, and the 10 gram by the IM. So this is the loading dose. This is the loading dose, and which is followed by the 5 gram IM every 4 minutes. So this is the maintenance dose. This is the maintenance dose. So this is the explaining perfectly and correctly about the magnesium sulfate. Okay, so very important. Which of the following correctly describes the Pritchard regimen for the magnesium sulfate administration? So that is the option C, is very perfectly explaining about the Pritchard regimen. Now you tell me which statement is explaining you about the Gestational regimen. Which option is explaining about the Gestational regimen? Yes, perfect. So here you can see we have the correct answer for this question. That is the option C. So how we are going to give the MgSO4 in the Pritchard regimen? So this is the Pritchard regimen. P bar R in the sense Pritchard regimen. This is for the magnesium sulfate administration in a patient with the eclampsia or in a patient of the preeclampsia with severe features. Sir, what is the purpose of the MgSO4? Purpose of the MgSO4 is to prevent the eclampsia and to treat the eclampsia. Sir, where we are going to give to prevent the eclampsia? I told a woman with a severe preeclampsia, or we can say the preeclampsia with severe feature, may anytime get converts into the seizures, and she may anytime get shows the seizures, and she may anytime get converts into the eclampsia. So whenever she is showing the impending sign of the eclampsia or the warning sign of the eclampsia, that time we will give the MgSO4. So that is to prevent the eclampsia. Once she started the seizure, so then we will give the MgSO4 to treat the eclampsia. Sir, is that a MgSO4 is in the anti-epileptic drug, sir? No. Then how it is going to reduce the seizure, sir? So the main reason here is this MgSO4 is the central vasodilator. Okay, so this is in the central central vasodilator. Okay, central vasodilator means it is going to increase the blood supply. It is going to increase blood supply to brain, and which will control the ischemia of the brain, and which will reduce the seizures in the eclamptic patient. Okay, yes. So this is the how we are, this is the reason why we are going to give the MgSO4. MgSO4 is given both for the prevention of the eclampsia and for the treatment of the eclampsia. Okay, yes. So now this MgSO4, which will be given in the two regimens. One is the Pritchard regimen, which is the accepted regimen in the low resource settings also, and in the high resource settings also we can give. But mostly which we will use the Pritchard regimen as the most common regimen in the low resource settings, like where infusion pump is not available in a PHC, CHC, and the taluka level hospitals, where the skilled stop or the infusion pump and the like costly equipments are not available. So that is called as the low resource settings. So there we are going to use the Pritchard regimen. And in the high resource settings like a tertiary level care, aims like hospitals, so we are going to use the Juspan regimen. Okay, yes. So but what Foxy recommends, Pritchard or Juspan means the Foxy current guidelines also, that is the Foxy current guidelines also recommends the Pritchard regimen only, so you have to keep in your mind. Okay, yes sir. So how we are giving the MgSO4? So that is we are giving this one in the loading dose and the maintenance dose. In the loading dose, so that is the 4 gram IV we are giving, so that is over the 5 to 10 minutes. Then the 10 gram I am giving. So 10 gram in the sense, so 5 gram in a right buttock, 5 gram in a left buttock. Okay, so in a right buttock 5 gram, in a left buttock 5 gram. So this is the loading dose I given. Okay, so after loading dose, what I am going to give? I am going to give the maintenance dose. So this is how I am giving maintenance dose. I am giving the intramuscular. Okay, so again 5 gram every 4th hourly I am repeating the dose. Okay, so this is continued. This is continued after the 24 hours after the last seizures, or we can say 24 hours after the delivery. So till this particular time we are going to continue the maintenance dose. Okay, yes sir. So this is how we are going to give the Pritchard regimen. 14 gram loading dose and 5 gram maintenance dose every 4th hourly we are repeating. Okay, in the 14 gram of the loading dose, 4 gram IV, that is 5 to 10 minutes I am giving, and the 10 gram IM, so that is I am giving, so that is by the intramuscular route. Okay, yes. So as I told, we have the two regimens. One is the Pritchard regimen, another one is the Juspan regimen. Sir, which one will ask in the exam? Sir, both asked in the exam. Okay, so this is also asked in the exam, and Juspan also asked in the exam. Sir, which one we need to study now? Both you need to study now. There is no any option. You want to score high, so these are the complicated topics you have to make easy. Okay, so let me take you to a beautiful ride on the difference between the Juspan regimen and the Pritchard regimen. So mainly where we are going to use this one, commonly used, the Pritchard will be used in the low resource settings and the Juspan will be used in the high resource settings. Low resource settings in the sense where without IV infusion pump, we don't have IV infusion pump there, we are going to use the Pritchard regimen. And if we have the infusion pump, so that time close monitoring is possible, so that time we are going to use the Juspan regimen. Okay, so how we are going to administer MgSO4 in the Pritchard? That is by both IV and IM. Sir, why IV also here? So I told here in the loading dose we are giving the 14 gram of the MgSO4. In this one, the first 4 gram, how I am giving? The first 4 gram I am giving the IV, so that is by the 5 to 10 minutes. So that is for the 5 to 10 minutes. Then remaining 10 gram I am giving? 10 gram I am giving by the intramuscular route. Okay, this is most important. 10 gram IM, 4 gram IV, so that is the 14 gram total, right? Yes sir. So the next most important is, here I am using the IM route also, IV route also. So that is Pritchard regimen will be given both by IV and IM route. Okay, and remember the Juspan only IV, no IM. So which one is painful, which one is like less painful? So this is the more painful. The Pritchard is the more painful. Juspan is the less painful. This is the less painful. Okay, so because we are not giving by IM, so that is the less painful. Okay, so what is the dose we are going to give in the loading dose of the Pritchard? What I told in the loading dose, 4 gram IV slowly over the 10 to 15, like 5 to 10 minutes, and 10 gram IM. So that is the 5 gram in each buttock with the lignocaine we are giving. Okay, so why is there lignocaine? Because it will cause the dangerous pain if you give without lignocaine. So that is the reason we will use the lignocaine also, so to administer the MGSO4. Okay, so next comes here as the 4 gram IV slowly for the 5 to 10 minutes. So this is in the Juspan regimen loading dose. Okay, yes sir. Maintenance dose in the Pritchard regimen. In the Pritchard regimen, maintenance dose will be, so that is the 5 gram IM administering. So that is every 4th hourly I am repeating the dose. So before repeating the every 4th hourly, what the 3 things what I need to monitor? I need to monitor the respiratory rate. So as per the new guidelines, it should be more than 16 breaths per minute, and deep tenant reflex. So I need to monitor, it should be positive. It should be positive. And most importantly, 4th hourly urine. Okay, so that is the Q4H urine output. If I am monitoring, means it should be more than 100 ml per 4 hours. Okay, or we can say more than 30 ml per hours. Okay, it should be more than 100 ml per 4 hour, or it should be more than 30 ml per hour. So these 3 things I need to monitor. One is the respiratory rate. It should be more than 16 breaths per minute. Deep tenant reflex, it should be positive. And the most importantly, every 4th hourly urine output, that should be more than 100 ml in a 4 hour, or the more than 30 ml in a 1 hour. So this is the very important thing to be keep in our mind. Okay, yes sir. Right, yes sir. So that is the how I am going to do the maintenance dose. But in the Juspan regimen maintenance dose, what I told, here we require the infusion pump to administer the MGSO4. So in the maintenance dose, we are giving the 1 to 2 gram of the MGSO4 per 1 hour. Okay, so you can consider 1 gram for 1 hour. So this is continuous IV infusion using the infusion pump. Okay, so that is the Juspan regimen. Right, yes sir. So next is, both will be continued for the at least 24 hours after the last seizure, or at least 24 hours after the last delivery. Okay, so both will be continued 24 hours after last seizure or the last delivery. And the respiratory rate, it should be more than 16 per minute, and the deep tenant reflex should be present, and the urine output should be more than 30 ml. So per hour I have told. Same thing we are going to monitor in the Juspan also. Okay, if the urine output is less than the 30 ml, so what you are going to do? Yes, if urine output is less than 30 ml, so first thing you are going to do is check the patency of the Foley's catheter. Okay, if the Foley's catheter is okay, then flush the Foley's catheter. Even after flushing the Foley's catheter, still the urine output is not there, then hold the drug. Okay, so that is the most important, right? And remember one scenario here. So that is the, as per the FOXY latest update, the FOXY guideline says that what scenario, if the respiratory rate is normal and deep tenant reflex is positive, only urine output is less than 30 ml per hour. Okay, so then what is the next nursing intervention? The next nursing intervention is, first we are going to check the urine patency, and urine is like the Foley's catheter patency. Foley's is patent means flush the Foley's catheter. Okay, even after flushing, still the urine output is like less, means so don't hold the drug now. Why? Because the respiratory rate is more than 16 breaths per minute. Normal in the sense it should be more than 16 breaths per minute. Okay, yes, so this is considered we will normal, means more than 16 respiratory rate is there, DTR is positive, which means so we are going to give the half of the maintenance dose, that is 5 gram on, sorry, 2.5 gram only we are going to give. So maintenance dose in the Pritchard, how much we are giving? So we are giving the 5 grams. Now we are giving the half of the 5 grams, that's the 2.5 grams. Okay, so that's very important, you must and should you have to keep in your mind. Okay, yes sir. So previously what happened, if the urine output is less than 30, hold it. Now if urine output is less than 30, check for the DTR, it is positive, check for the respiratory rate more than 16, give the half. Okay, so don't give the full dose. Okay, so this is the new update, so this is the latest update. Okay, so give the half gram or the 2.5 gram of the MgSO4, so that is the intramuscular we can give, or we can say this is the half of the our maintenance dose. Okay, so this is very very important, sir. Now if the respiratory rate is less than 60, what we are going to do? Withhold. DTR is absent, what we are going to do? Withhold. Urine output is less than 30 ml, so then check for these two, if both two are normal, give half, if two are abnormal, withhold. That's it. Okay, so I hope it is very much clear, right? Yes sir. So next most important thing is, I told both should be, means MgSO4 should be continued at least 24 hours after the last seizure or the delivery. Okay, and monitoring also we have done, and commonly used I told, in a low resource setting Pritchard is best, and high resource setting Juspan is best. And the Pritchard is doesn't require the infusion pump, but Juspan regimen requiring the infusion pump, and most importantly it requires the proper monitoring. If there is no monitoring, so that is difficult, because we are giving the IV, right? So that is the most important. And remember, the Pritchard regimen is very painful, risk of the injection site abscess and necrosis also may there. And in the Juspan it is required the infusion pump, so that is not most painful, but it is very costly. Okay, so Juspan regimen is costly, so I hope it is very much clear to every one of you, right? Yes sir. So next concept which we are discussing now here is this one. Which of the following best describes the component of the HELP syndrome? Component of the HELP syndrome. Option A is the hemorrhage, elevated lipase, or low platelet. Then B comes to hemolysis, elevated liver enzyme, and the low platelet. C comes here as the hypertension, edema, and low protein. D comes here as the hyperglycemia, elevated lipase, and leukocytosis. So what is your correct answer? What may be the perfect answer here? So what? Which of the following best describes the component of the HELP syndrome here? Yes? What? Well done. So that is the option B goes to the correct answer. Hemolysis, elevated liver enzyme, and low platelet. So this is the simple direct question. In the exam, the question comes in another form also. Sir, how? So you can see here, HELP in the sense we written here, the H in the sense here the hemolysis. If hemolysis is there, means we can say this one as the anemia. Yes. So examiner can give the anemia word instead of the hemolysis. Okay. Yes. Be very much cautious here. Okay. Yes. Hemolysis means anemia. We can accept that. Then the EL is the elevated liver enzyme. So he can mention the direct instead of the elevated liver enzyme, he can mention that lipase is increased. Sorry, other liver enzymes are increased. Okay. And ELP he written that is the low platelet. Low platelet, instead of the low platelet, he can write the thrombocytopenia. Right? Yes, sir. So this is the most important. Thrombocytopenia, anemia, and elevated liver enzyme is also a part of the HELP syndrome. Okay, so that is the HELP stands for this one. That is the H is the hemolysis, EL is the elevated liver enzyme, ELP is the low platelet. Okay, so these are the components of the HELP syndrome. We must and should we need to keep in our mind. Okay, is that clear? Fatafa do thumbs up. Is that clear to every one of you? I want response from all of you. All of you. Yes? Perfect. So here it comes to the next question. Chalo. What is the definitive treatment for the pregnancy-induced hypertension and the preeclampsia is the question. The definitive treatment of the pregnancy-induced hypertension and preeclampsia. This is the question now. Option is the antihypertensive medications we need to give. B is the magnesium sulfate administration we need to do. And C comes as the bed rest and the dietary modification. Then D is the delivery of the fetus and the placenta. So now you tell me, in the pregnancy-induced hypertension and preeclampsia, is that salt restriction and all beneficial? I am going to do the salt restriction. Is that useful or is this beneficial in the pregnancy-induced hypertension or preeclampsia? No, it is not useful, because here the hypertension and all not happening due to the circulatory overload and the fluid retention. It is not happening due to that one. Here it is happening due to the problem of the placenta. So here the bed rest, dietary modification, there is no use. Okay. So in the PIH and the preeclampsia, bed rest and dietary modification, especially salt restriction and all, no useful. Okay. So remember, write the very important word. There is in the salt restriction is not useful. Okay, so write it down. Very important, because the PIH and preeclampsia is a problem of the placenta. Okay. Yes, option A is the antihypertensive medications. This is just to control the blood pressure, not to as a definitive management. Okay, here the question is about the definitive treatment. Okay, the antihypertensive is only to reduce the BP. Then option B is the magnesium sulfate administration. So this is the prevention of the eclampsia and treatment of the eclampsia. So this is not for the management of the other definite. This is not in the final or the definitive management of the PIH or the preeclampsia. Then what is the answer, sir? When we can say the definitive management of the pregnancy-induced hypertension, so that's the delivery of the fetus and the placenta, because this is the problem of the placenta. So the question will when we are going to deliver the fetus and placenta. When we are going to deliver the fetus and placenta. So based on the condition, you are going to deliver the fetus and placenta. So there is the time of the placenta and fetus delivery and the conditions. This one is must and should. You need to know here. Okay. So in case of the mild preeclampsia, we will call this one as the preeclampsia without severe picture. Preeclampsia without severe picture or the mild preeclampsia. In this condition, we need to deliver the placenta and fetus after the 37 week. In case of the severe preeclampsia or preeclampsia with severe pictures, that time we need to deliver the placenta at 34 week or after the 34 week. And in case of eclampsia, HELP syndrome, PIH with abruptio placenta, PIH with fetal distress, no need to wait, just immediately deliver the baby. So otherwise baby is going to die. So this is the very important points we must and should need to keep in our mind. Okay, and here it comes to the next question. So I hope the answer for this question is very much clear. Yes. So the next question comes here. Which of the following is not a preferred first line antihypertensive drug for managing the pregnancy-induced hypertension? So question you have to focus, not preferred. Okay. Yes. As for the FOXY guidelines 2026, you must answer. Which one is not preferred anti-hypertensive drugs in a pregnancy-induced hypertension? Option E, labetalol. Labetalol is the best drug and always most commonly used drug. Okay, so that is the most commonly used or the best drug is always labetalol. So in the question they are mentioning not used. So this is used or this is the preferred. And methyl dopa oral. So this is the most safest drug in the pregnancy. Okay, so this is the most safest antihypertensive drug. Yes. Then nifedipine oral. This is also preferred. This is also used nowadays. Then what about enalapril, sir? Yes, very nice. So this is not preferred one is the option C. So can anyone say why this enalapril is not preferred? Anyone want to say why this enalapril is not preferred? So this enalapril is a classification of the S angiotensin converting enzyme inhibitor. Okay, so this is the ACE inhibitor. Okay, so this is in the ACE inhibitor, right? Yes. So what this enalapril will do? So this is having the teratogenic effect. So this is having the teratogenic effect. It is going to damage the baby in a very next level. Okay, so that what are the teratogenic effect it is having, sir? What is the teratogenic effect which is having? Yes. So first teratogenic effect which you can keep in your mind is there is a lung hypoplasia. Okay, lung hypoplasia means lungs will not develop properly. Okay, so after the lungs hypoplasia, what you are going to keep in your mind? The next one is the renal agenesis. Okay, so next one is the renal agenesis. Very important. So these are the two very dangerous, and one more which we have. If the mother is taking the AC inhibitors, so it will cause the oligohydramnios. Okay, yes. So these are the dangerous effect of the ACE inhibitors or the angiotensin converting enzyme inhibitors. There is the lung hypoplasia is there, renal agenesis is there, oligohydramnios is there. So these are the effect which will comes when the woman will take the enalapril, that is during the pregnancy. So that is the reason all the pills, that is the what you can say a captopril, enalapril. So these all pills are contraindicated in the pregnancy. So this is very, very important. We need to keep in our mind. Okay, yes, sir. So then what else other things contraindicated? So can we give the aldosterone receptor blockers? That is the telmisartan, losartan. Can we give this one? Can we give the aldosterone receptor blockers? No. Aldosterone receptor blockers, that is the telmisartan, losartan, those are also contraindicated. Okay, so those are also contraindicated. Sir, can we give the diuretics like loop diuretics, thiazide diuretics, hydrochlorodiuretics, so hydrothiazide diuretics, whatever the diuretics are there. So can we give the diuretics? No. Diuretics also contraindicated in the pregnancy. So please do keep in mind. Sir, can we give the only beta blockers? Only beta blockers also contraindicated in the pregnancy. Sir, then you are giving the labetalol, sir. Labetalol is not an only beta blocker. It is on the alpha plus beta blockers. So the labetalol we can give, not only beta blockers. Okay, yes. So please do keep in our mind, this labetalol is the safest, sorry, this is the most commonly used and the best one. And remember, nowadays we have the restriction over this one. If the patient means the pregnant woman is known case of the asthma, or if the heart rate is less than 100 beats per minute heart rate, in this particular situation, the labetalol is not useful. So this is not useful. So then which one we are going to use, sir? So you can listen here. You can see here. So most commonly used drug, what I told, most commonly used one is the labetalol. But if the woman is known case of asthma or the pulse rate or the heart rate is less than 100 beats per minute, so the nifedipine oral we are going to use. So please do keep in mind. Okay, yes, sir. So this is most important. And the drugs which we are using in the pregnancy-induced hypertension is, so as per the Foxy guidelines 2026, first one is the M, then N, then L. So you can write L, M, N, O. We can write, yes, sir. A, B, C, D, E, F, Z, L, M, N, O, P. Yes, L, M, N, O. We can write, yes, sir. So we are giving the labetalol, we are giving the methyl dopa, we are giving the nifedipine, that is by oral route. Okay, so that is the LMNO. You can write. Okay, so LMNO are the drugs which is using in the mild PIH. So that is, we can say the BP is persistently increasing. So that is the time where we are going to give the our LMNO. That is the labetalol, methyl dopa, nifedipine by oral route. Okay, so I hope it is clear. Among this one, most commonly used one is the labetalol, but it not be given if the asthma case is there and the pulse rate is less than 100 beats per minute. So why not in the asthma? It is in the beta blocker which will blocks the beta action. So there is no bronchodilation. So there is the bronchoconstriction may happen. The bronchoconstriction is happening means, yes, bronchoconstriction happening means the further worsening of the asthma will happen. So we will not go. And it's the beta blockers which will further reduces the heart rate. So that is the reason if heart rate is less than 100, we will not give the labetalol. Okay, yes, sir. So I hope it is clear to every one of you. Is that clear to every one of you? Yes. So the next most important question is this. Which of the following antihypertensive drug is not contraindicated in pregnancy? Not contraindicated. So what I told, enalapril, so all the prils are contraindicated because of the lung hypoplasia, renal agenesis, and the oligohydramnios. And the diuretics, all the diuretics are contraindicated in the pregnancy. And the sartans, so there's all the angiotensin receptor blockers, there's the sartans are contraindicated in the pregnancy. And the methyl dopa is the safest drug in the pregnancy, so we can give this one. Okay, so this is then the which is not contraindicated in the pregnancy. So very important to be keep in our mind. Okay, yes. So the next question is this. So the drugs which we are using in the severe pregnancy-induced hypertension, we will discuss now. So the drugs which we are using in the severe PIH are the PIH with severe symptoms. So that is blood pressure is more than 160 by 100 mm of Hg. This is an emergency. We need to treat the patient within 1 hour. Otherwise, we are going to make the patient complete whole body edema and BP is irreversible. So that may goes to patient may land to death. Okay, so here the Foxy recommends the first line drugs, that is again labetalol, nifedipine, nicardipine. And here the methyl dopa is not useful. In the sudden high the BP and in the severe blood pressure, methyl dopa is not useful. Sir, why? Why? Because it will act very slowly. It will act very slowly. That is the only reason. It is the safest drug, but not most effective drug. It is the safest. Methyl dopa is the safest, but not most effective. Are you getting the point? So that is the reason. You can see in the severe PIH, we are not using the methyl dopa. Okay. So we have the labetalol, that is by IV route, nifedipine, that is by the oral, and hydralazine by the IV route. Okay. So then nicardipine, which is recently added, new one. So that is by the also IV route. Okay. So sir, single best answer, sir, that is the labetalol. Okay. Yes, sir. Then oral nifedipine we will use, hydralazine. So after the labetalol is a single best answer, which is the second best, sir, the hydralazine. Okay. So this is a very important to be keep in our mind. Okay. Yes, sir. And you can see the MGSO for magnesium sulfate is the drug of choice for the seizure prevention and the treatment. Okay. So in the severe preeclampsia, we are giving to prevent the eclampsia, and in eclampsia we are going to treat the eclampsia. Okay. So that is to treat the seizures. Okay. Yes. So the next most important is this one. So that is the dosing protocols of the our IV labetalol. How we are going to give the IV labetalol in a case of the severe PIH or the PIH with severe symptoms, or we can say in the hypertensive urgency in the pregnancy. How we are going to give the labetalol? Yes. What is the total dose? You tell me just a total dose, how much we can give the maximum. Maximum we can give is the 220 mg. Okay, sir. Then how we are going to give the 220 mg, sir? You can see. So dosing standard protocol of the labetalol is like this. First 20 mg we will give, that is by IV bolus over 2 minutes. Okay, yes, sir. Then we will wait for the 10 minutes. We will check the blood pressure. If it is comes to normal, okay, no need to repeat again. If still the blood pressure is high, so double the dose. The 40 mg IV I am going to give. Then I will wait for the 10 minutes again. Still the blood pressure is not under control. Then again double the dose, 80 mg I am going to give. So then again I will wait for the 10 minutes and I will check the blood pressure. Still not under control, I will go for the again 80 mg of the labetalol. So this is IV route only. Okay, so we will repeat if it is necessary. If not necessary, BP comes to the normal, that is okay, we will not repeat. Total how much we are using, so you can count it down. That's the 80 mg, 80 mg is the 160 mg, plus 40 is the 200 mg, plus 20 is the 220 mg we are using. Okay, so this may be the question. Maximum total dose of the labetalol in the severe high, like increase in the blood pressure in the pregnancy, that is the 220. That is the 220 mg. Okay, so is that clear to every one of you? Yes. So the next question comes here. What is the first step in the nursing management of a woman who is persisting with the eclamptic seizure? So the now woman is having the eclamptic seizure. Now woman is having the eclamptic seizure. Already seizure have been started. Who is persisting? Who is having a seizure? What is the first step in the management? What is the first step in the nursing management? Option A, immediately deliver the baby. Yes, we will deliver the baby, but it is not a first step. It is the definitive management, but it is not a first step. So first step always should be goes to the airway, breathing, circulation in a patient with a seizures. Okay, so that is the reason the immediately after the patient start to throw the seizures, you have to give the left lateral position to secure the airway. Otherwise, all the secretion which is producing in the mouth may patient aspirate, and the aspiration may causes the a dangerous effect over the lungs, and that may cause the various other adverse effect. Okay, yes. So most importantly, please do keep in your mind, immediate delivery of the baby is the definitive management, but it is not in the first step. So I am eliminating the option A. Then comes to the B, administration of the intravenous magnesium sulfate. We will do, but after making the airway secure. Okay. Then option C is the administration of the antihypertensive drugs. Also we will give, but after securing the airway. So that is first step in the nursing management is the, so that is the option D, that is the give lateral position. And almost all you people given the very perfect answer for this question. So that's I am very proud of you all. Okay, so I am very proud of you all. The next question comes here, the types of the eclampsia. So what are the types of eclampsia we have? What are the types of the eclampsia we have? Eclampsia are here are the three types. One is the eclampsia antenatal, eclampsia internatal or the internatal eclampsia. Then the postnatal eclampsia means during the period of the pregnancy, during the pregnancy period or during the antenatal period, the woman is having the high blood pressure, proteinuria and seizures. So this is in the eclampsia of the antenatal. This is the most common type of the eclampsia, and this is the most worst type of the eclampsia. That is the eclampsia antenatal. Okay, eclampsia antenatal is the high blood pressure, proteinuria and seizures happening in a pregnancy period. So that is the eclampsia antenatal. This is the most common type of the eclampsia and most worst kind of the eclampsia. That is the eclampsia antenatal. And we have the internatal eclampsia. In the internatal eclampsia, what happening here? So this is happening during the labor process. This is happening during the labor process. So during the intranatal period it is happening. So this is on the intranatal eclampsia. And after the delivery happening, within 24 hours after the delivery which is happening, this that's the postnatal eclampsia. Okay, so postnatal eclampsia is the within 24 hours after the delivery is the postnatal eclampsia. Very important for the exam, so please do keep in your mind. From here you may expect a question in your exam. Okay, so I hope it's very much clear. The three types of the eclampsia, that's the eclampsia antenatal, eclampsia internatal and eclampsia postnatal. So within 24 hours after the delivery is the postnatal eclampsia. Okay, so during delivery which happening is the internatal eclampsia, and during the pregnancy happening, that is the most worst, most common type is the antenatal eclampsia. I hope it is very much clear to every one of you, right? Yes. The next very important thing is this one is your assignment question. What is the antidote for the magnesium sulfate toxicity? So this is our first assignment question. And the second question which is there here is drug used in the cardiac membrane stabilization in the hyperkalemia. Okay, cardiac membrane stabilization. Patient is having the hyperkalemia. In this patient, you want to make the cardiac membrane stabilization. What is the drug you are going to use? And the third question is drug which need to keep bedside of post thyroidectomy. post thyroidectomy and during the exchange blood transfusion and during the blood transfusion also. Okay, yes. So which drug is this one? The answer for this all question is the single. Antidote for the magnesium sulfate toxicity is also, and cardiac membrane stabilizer in the hyperkalemic patient also, and drug which we need to keep bedside of the post thyroidectomy case and in the exchange blood transfusion case and in the blood transfusion situation. Okay, and along with this one, so drug which will use in the hypocalcemia, one more we can write. Okay, so that is the drug used in the hypocalcemia. Drug used in the hypocalcemia. So answer for this all question is one answer. So I want every one of you to give your answer in the comment box. I hope that today's session you have enjoyed a lot. Okay, and in the next session we will meet with a more powerful and the more informative session. So that is, as the days comes near, so the most important question comes to you. Don't miss any upcoming classes because you will regret after the exam. Okay, yes, especially upcoming classes don't miss. So that is a special clue from my side, so that a direct questions which strikes on your computer screen, which is going to come very soon, don't miss, and keep on revising your theory notebook so no one can stop your selection. So I hope you enjoyed the today's session, and the candidates who are preparing for the upcoming Norcet 11 exam, for those candidates so who are already passed out, so please do refer our classes to the candidates who are preparing for the upcoming Norcet 11 exam. So that is A1 plan which we have, and who are using our test series. So please do refer the test series. If you like the test series content, questions, and the different type of the questions like match the following questions, image based questions, assertion reason based questions, only the master nursing classes in India is giving those kind of the different practice questions to make you very fit for the exams. So here we have the plan A1, that is the basic to advanced preparation plan for the upcoming Norcet 11 and 12 and the JIPMER and the CRE senior nursing officer exam. Okay, so here it is. This plan is having the full-fledged high quality best to best content of the classes and the daily live test series, subject wise test series, and the most importantly the continuous support from the expert team. So that is very necessary to guide you, motivate you, keep you consistent throughout your preparation. Okay, so thank you so much for watching the video till here. So please do share the class with your WhatsApp status and all, so that we can reach the other members also. Okay, so thank you. We will meet again. Bye bye. Check. Thank you to every one of you. Right. So we will meet with the tomorrow's class. Bye bye.